for 10 years into my career, I had 2 kids, 2 little boys, and which was great. But I think that really changed the way I viewed myself, the way I viewed my career and what I wanted.
Welcome back, everyone, to HPG Engage, the podcast. Today, I have the pleasure of speaking to Dr. Jillian Eyles. How are you today?
Very well, thanks.
First of all, thank you very, very much for sitting down with us today to have a quick chat about you, your career, how you've navigated that, and basically you and your research and what you've been getting up to. It'll be good to sit down with you, talk to you about that aspect of your career, and then how you move from that into your research in osteoarthritis. But just to start off, could you just take us back to your university degree, the area that you obviously study in physiotherapy, and why that was the choice that you made back then?
Sure, and thanks so much for having me today, Dwayne. It's an absolute pleasure to share my journey with you. So yes, I'm a physiotherapist. So I did that for almost 15 years, so quite a long time.
So was physiotherapy and spinal cord injury, was that the whole 15 years, or were you just doing spinal cord injury for 15 years? Just trying to work out, did you do physiotherapy for a while and then transition into spinal cord injury, or was it kind of straight into spinal cord injury when you moved here to North Shore? Yeah,
so I worked in every area you could possibly do. So we do an intern year as a physiotherapist, and you basically get a taste of working in every area, which is incredible and really great for building skills. And then after that year, I came into the spinal injuries unit because I was lucky there was a position available, and I also supplemented that. As I was working over the years, I actually randomly also worked in childbirth education, which was amazing and really interesting. So more of a health promotion type role. So working with parents, new parents to be, and working through the birthing process and early parenting stuff. So that was a really fun job. And I also did exercise classes for pregnant women and post Pilates classes for after. And I did a bit of private practice work as well. So I guess I did have a few different jobs.
Your toes in there quite a lot. And I guess that's what happens when you first start out in an area within, I guess, physiotherapy or in any part of healthcare. It is really important for you to dip your toes in as many different ponds as you can, just so you can get a feel for it and then also know exactly what you really want to do.
Yeah. And you probably also touched on that, Dwayne. It's important to know about me that I'm not very good at doing the same thing every day. So I really like doing different things.
That's good.
Always. Yeah. And spinal injuries was like that. Though it's a huge area. But yeah, I seem to not be able to concentrate on one thing at the one time for very long. So that's why I did lots of different things. And I guess that's kind of what then led me on later to what I was doing and then moving into research.
Yeah. So you obviously were doing spinal cord injury for 15 years.
Yep.
And then you decided to move into osteoarthritis.
Yes.
Why was that?
Yeah. So it sounds a bit like it doesn't fit very well, but but in my head it does.
It did.
Yeah. So I guess for 10 years into my career, I had 2 kids, 2 little boys, and which was great. But I think that really changed the way I viewed myself, the way I viewed my career and what I wanted.
Yeah.
So, as a woman and as a parent and as a professional person, you have to come up with a really clever plan as to how you're going to navigate parenthood and your career and all that sort of stuff. So for me, I juggled everything quite well and I was lucky to be able to do my job and do what I wanted to do with my kids. But what I found was I had an underlying need to then push that career envelope. So after the kids were a few years old, I had this overwhelming desire to really change up what I was doing and to progress my career, because I always felt like I was kind of siloed, but I describe it as treading water while the kids were small. Treading water. And it was fine. I was keeping my head above water, but it was, I really wanted that next step. And physio is quite even though it's a wonderful career, there's quite a glass ceiling. So I'd reached the top. I was senior in my area. There wasn't really anywhere I could go further in spinal cord injury without doing a further degree or moving into management, which wasn't really what I wanted to do. And during my work in spinal cord injuries, I had this wonderful mentor, Professor Lisa Harvey, who is an amazing spinal cord injuries researcher. She involved me in several randomised trials as a clinician when I was working, and I was very inspired by that. So I always kind of knew that I had this underlying desire to do some sort of research degree, so a higher research degree. And funnily enough, it came up. An opportunity came up in osteoarthritis. And so it kind of timed out when I was looking for something new. I wanted to work in a new area, that an opportunity in osteoarthritis came up here at Royal North Shore and the Kolling Institute. The hospital was rolling out a new osteoarthritis chronic care program, which is it's a very holistic program, a person-centred program to help people with osteoarthritis self-manage their condition. And the main tenets that underpin the whole program comes back to exercise, physical activity, the overall holistic eating, healthy, maintaining a healthy weight, all of those things that are really important around healthy lifestyle. So really, I thought, wow, fantastic. This program really embodies what you're so passionate about. Exactly. My passions of staying healthy, staying active, all those sorts of things. So it was great. So I had an opportunity to do some evaluation of some of the patient data coming out of this new program. And then that sort of turned into a PhD program. So I did my PhD on the osteoarthritis chronic care program. And people often ask me why osteoarthritis.
That was going to be my next question.
Sorry, I probably cut you off with that.
No, it's all good.
So osteoarthritis is quite near and dear to me. I've got several family members that have had really severe osteoarthritis and lived with it in the past. So there's actually a really strong genetic link with osteoarthritis. So chances are I'll probably end up with some of it myself. But I can also see that in practice, a lot of people suffer for a lot of years with osteoarthritis without any help or treatment. Exactly. And we know exactly what people with osteoarthritis need. So they really need to keep moving. They really need to be active, keep their muscles strong. And they also really need to maintain a healthy body weight, so not get too heavy for their joints. And so those things don't get implemented in clinical practice. So
we find there's a lack of knowledge with, I guess, the general public more so than clinicians, where you've got osteoarthritis, but a major aspect of kind of trying to reduce the pain is to constantly try to be as active as possible. Obviously it's kind of, you're going around in circles, because when you're in a lot of pain you don't really want to move, but then it's kind of, I guess it's kind of teaching people, actually the pain may be there, but this is gonna make you that little bit better. Do you find that's a struggle? Definitely.
So there's a few sort of factors that play into that as well. So back in my uni days as a physio, we were basically taught, someone with osteoarthritis, there's not much you can do. Just tell them to go away and they can have a joint replacement when their joint gets that bad. And that's seriously what the management was like 20 years ago when I did my training. But we know now that that's really not the case.
That should be like a last
Yeah.
That should be the last option usually.
So joint replacement is definitely last option. So as last resort, right at the end of the disease, if it gets that far that people, if they need a joint replacement, then it's a really great treatment. But not everyone's going to need a joint replacement, so that's one thing people have a real problem with. And when I say people, I mean the general public. A lot of the general public believe that they're inevitably going to have a joint replacement, which is just not true.
Yeah.
Which is good news.
Why do you think that is? Why do you think that's the option that people think they'll need to get?
Yeah, so I think it's born out of the fact that they go along, they see their GP, they say, I've got a really sore knee, it's been sore for the last few months. And the GP says, well, there's not really much I can do about it. I'll send you off to the orthopaedic surgeon. We'll get some scans and you can go and make an appointment. And then that little person comes up to the orthopaedic surgeon. They look at the scans and they say, well, I don't know, how are you feeling? Is it that bad? Do you need your replacement yet? Or can we wait a while? Because maybe you might be able to wait a little bit, or you can have a surgery now. So it's quite freely offered, the joint replacement surgery. And not everybody actually needs it. And we know that people whose symptoms aren't very bad, they actually don't do very well from joint replacement surgery. So unless you're in lots and lots of pain and lots of disability, the joint replacement doesn't seem to go as well. Yeah. That's what the data is telling us. Yeah, so there's that real disconnect, particularly in primary care, that GPs don't really know what to do with the person until they're bad enough to go and see the orthopaedic surgeon. And I think that's why people think that joint replacement is inevitable. If you have osteoarthritis, you need to go and see the orthopaedic surgeon, which is just not necessarily true.
Yeah.
Yeah. So that's definitely a big barrier. The other really big barrier is, I think, over time, osteoarthritis as a disease has got a really bad reputation because it's a wear and tear and it's an old age thing. So wear and tear meaning that if you exercise more, you'll wear out your joint more, which is also not true. So that's a myth that you have to debunk with people with osteoarthritis all the time. So that really plays into it as well.
Talk to me a little bit about your research with David Hunter.
Yeah, so David Hunter works here at the Kolling and at Royal North Shore Hospital. So he was the founder of the program here at North Shore, the Osteoarthritis Chronic Care Program. So he had this vision to implement best evidence care, person-centred, holistic, considering the whole person with their comorbidities, everything that they do in their life, what's important to them, and try to work out how a good management program to get them to healthier, fitter, and more able to manage their osteoarthritis. That was his vision.
Yeah, for sure.
And that's what was sort of been delivered in this program. So for me, my first job was to evaluate that program and look at the outcomes, and then I was trying to develop, I guess, a patient profile or prognostic factors that tell us that people were going to do well from the program, or people who weren't going to do so well from the program and maybe needed to go and get their joint replaced. So that was my PhD. And then from there, what I moved on to is more seriously thinking about how we can support health care professionals to deliver these exercise and weight loss interventions and teach people to self-manage. So it's great if they get onto an osteoarthritis chronic care program and they're very supported and all the staff know exactly what to do.
Yeah.
But if they're out in the community and they're seeing their local GP or primary care provider, that they're actually getting the right care. So some of the projects we're doing at the moment, we're doing a really big e-learning program that will be ready at the end of the year, actually, that is funded by the Australian Department of Health, which is exciting, and we're making it available to all healthcare professionals to teach them about how to actually manage osteoarthritis and give them lots of resources and tips as to what to do. But we're also implementing that internationally. So we've got some really amazing colleagues overseas, collaborators. We have quite a large organisation of international researchers and clinicians that are and consumers that are really passionate about this. So hopefully we'll go global with the e-learning program. We're hoping we can take over the world with that one and really disseminate the important information about how to actually treat osteoarthritis.
That's so good. And in terms of the non-surgical method and the treatment that you guys are doing here, what's kind of the criteria for choosing patients to get in on your research?
Yeah, so criteria for patients for the program is basically anybody with hip or knee osteoarthritis. So it's really open to anyone.
Okay, so it's not really an age thing, it's just...
No, and 1 in 5 people over 45 in Australia actually have osteoarthritis.
That's a lot.
1 in 5 over 45. That's crazy. That comes from the Australian Institute of Health and Welfare.
I remember you actually touched on the global burden of disease to me when we last spoke. You'd said that osteoarthritis, even though it's not deemed to be critical in terms of the need for the research and the need for treatment, it's up there in the top 5, did you say?
Well, it's in the top 10. So top 10? Musculoskeletal diseases come in one after mental health. As far as burden of disease in the world.
And that's because it's not taken probably just as serious, or maybe it's getting to a level where it is being taken serious. But generally, when you have pain in some sort of joint, in this case osteoarthritis, a lot of people get so used to the pain that they don't really deem it as critical. That's
true. So that was kind of what I was almost going to say a little bit earlier as well, is that it's not seen as an important disease because it doesn't kill you.
Yeah.
So it has very similar risk factors to really important diseases like heart disease and diabetes, but it's not seen as important. However, it actually travels along with those diseases. So a lot of people with osteoarthritis will have those sorts of cardiovascular hypertension, things like that go along with their osteoarthritis as well. So those lifestyle interventions for those people are not just going to benefit their osteoarthritis, it's also going to benefit all of their other comorbidities as well. And that's why this program, the Osteoarthritis Chronic Care Program, was so amazing, because it's just it's such a whole person centered approach.
You touched on the e-learning aspect that you're going to be hopefully spreading worldwide.
Yep.
But you also talked about primary care and GPs as well. Do you think there is a slight gap between what you guys are doing here and your research and what GPs are aware of in terms of the holistic point of view? You'd mentioned to me about someone could come into a GP with osteoarthritis pain, but then they'll also have something wrong cardiovascularly. But the likelihood of the GP addressing both and trying to figure out why are these both things happening is very unlikely at the moment. They would maybe 9 times out of 10 just concentrate on the cardiovascular side, whenever there's a good chance that both of these actually are in conjunction with each other. You're having this issue because of that. Do you feel like with e-learning that's going to be something that will be addressed, that again we're going back to the holistic point of view aspect, that everything in the body comes together as one? So one aspect of you, in this case, my example, cardiovascular, has an effect on the osteoarthritis side of someone.
Definitely. And I mean, to give GPs all credit due, they're amazing. They often only have very, very short appointment times with people.
Yeah.
And if you have someone coming in with a sore knee and chest pain, or whose blood pressure is elevated, of course, you've got to address the elevated blood pressure before you, and obviously the chest pain, before you talk about their sore knee. But I guess that's what we're really trying to get across, is that these things are really interlinked. They often travel along together, and there are definitely things that you can do that can benefit all of the conditions together. And that's all about exercise, healthy eating, maintaining a healthy weight, all those sorts of lifestyle things. And maybe with a GP doesn't need to be able to deliver all of these treatments themselves, because they're simply not going to have time in the short appointments that they have with people. But they need to know how to then direct the patient onto someone who can actually give them some help. Yeah, and that's part of what we're trying to get across with the e-learning program and some of the other work that we're doing.
Awesome. Obviously, you're doing research and it costs a lot of money. for you to get paid, for your associate to get paid, for your PhD students to get paid for equipment.
Yep.
What are some of the roadblocks that you guys are actually experiencing, and what have you experienced?
So this is a hot topic with researchers. There are a few issues that play into funding for people who want to do research. I think it's a bit of a shock to a lot of people that as a full-time researcher with the University of Sydney or any other university, most often that researcher actually has to find their own funding. So unless you're really lucky and you've got a full-time research position, which is absolutely
very
like
hard
hen's
to get.
teeth, yeah. Especially as an early researcher, you have to hunt around and try and find money to actually fund your program of research, and that's getting tighter and tighter and tighter for various reasons. One of the major funders of research in Australia is the National Health Medical Research Council, the NHMRC, and to actually get a grant from the NHMRC is incredibly competitive. So the absolute pinnacle for a researcher like myself who wants to do full-time research or even part-time research is to get what's called an investigator grant. It's like a fellowship, and it goes for 5 years and it pays for your salary. But to get there, you have to have a really great track record. And when I say great track record, I mean 9% of people who put in an application for one of these things actually gets funded.
Very small.
91% don't get funded. So it's really hard. So you have to make your track record look amazing to get any funding to do the work that you want to do. But the problem is with it, as an early career researcher like me, I'm only 3 years post PhD. I'm competing with people who might have had 10 years since their PhD. So, of course, they've written lots more papers, got lots more grants, so can demonstrate lots more successful projects. So that's a real problem for a lot of early career researchers, and it's why a lot of people don't actually
How do you combat that then if you're going against? Because obviously a lot of people, you have the government grants, which most researchers in the country are trying to get into one pot of money.
That's right.
So, as you said, 5 years is the most ideal situation. How do you combat that? I know here at North Shore you have the North Foundation,
yes,
which is a great foundation which helps a lot of you guys here in doing your research to get those grants and to get money via philanthropy. So talk to me a little bit about that.
Okay, yes, it's my absolute pleasure to talk about that. So getting those little small pots of money to actually start a project and to generate some data is really, really important to put in the bigger grants. So for someone like me, if there's an amazing philanthropic donor that says we want to put some money into some research on osteoarthritis, and it can start me off on being able to show some outcomes and really develop up a really nice looking project for a bigger grant application, it's absolutely amazing. And the North Foundation are incredible. They work with us to set us up with potential donors that might want to fund some of our research. And so that's a really critical role that philanthropic donors can play, especially for someone like me who's so early in her career, to sort of get me started. So it's a bit of a startup. So I've got a new project that I'm very, very, very grateful to have some funding from the Gergensen Foundation, an amazing people who have I'm kind of speechless when I say it because I think it's so amazing. It's a new project. We're trying to reduce the amount of arthroscopy that's done in Australia. So arthroscopy is really recommended against in osteoarthritis. You really shouldn't be giving somebody with knee osteoarthritis an arthroscopy. And we know that. We've known it for a long time, but we still have 30,000 a year happening in our health system.
Explain to people listening what exactly is that.
So a knee arthroscopy in the presence of osteoarthritis, usually you'd go in with some cameras and some instruments and do a bit of a clean out and a tidy up.
Like scraping off.
Yeah. So you hear people say, I had my knee cleaned out, and they wash it out and clean it up a bit inside. And what we know is that's really not effective, and in fact could actually cause the person harm. So we really shouldn't be seeing people with osteoarthritis having those procedures, but we're still seeing it.
Is that procedure good for any particular reason?
Oh, it's very, very good if you have a flap of cartilage that's making your knee lock and you need that fixed, for sure.
So, but if it's osteoarthritis, it's not recommended?
No, that's it. And it's very clear in the clinical guidelines, and Medicare makes it really clear that you shouldn't be billing for those sorts of items for people with osteoarthritis. But like I said, we've got about 30,000 a year that still happen in people who have osteoarthritis. So the Gergensen Foundation are teaming up with us to develop a project. Yeah, it is amazing. To develop an intervention to try and stop those procedures from happening before they do in Australia. So that's some really exciting new work.
That's exciting. I think touching back on the philanthropic aspect of things, I think it's so important that people are aware of how expensive doing a lot of this research is. Before I really started working in this healthcare space and understanding how research works, how clinical research works, outside the pharma side of things, I didn't realize how much money is needed, because when you're out on the outside, you're just assuming this is just getting done, and like any other corporate company, you make money and then you pay your staff, but it's not really like that. And when it comes to like yourself, in terms of your fellow and doing your research, it really is a grind if you're lucky, every 5 years just to get a paycheck and just for you to do the research, and then another grind again just to get money to ensure that everyone else in your staff gets paid, that you have enough money for your equipment and all of that. And I think it's such an important aspect of your role that people should really be aware of.
Yeah. And I mean, it makes it sound really awful, but I was about to cry. The pressure. No, it is like that. That's the reality. It is, I mean, really, in Australia as a researcher, it's a privilege to work in research, which I really understand, because, you know, we're basically paid to pursue our interests and what we want to do. But of course, what we want to do is actually improve the healthcare system. Exactly. 100%. So that we improve people's lives. So, I don't know how we fix the problem besides pouring a bit more money into the research sector.
Exactly.
But yeah, so philanthropy's amazing. I also got a really a nice little grant from the University Clinical Trial Centre as well, which was amazing for this project too. So putting those little pots of money at the start of a project to build something really fantastic and big is kind of what you have to do. Yeah, it's really important.
And then that leads me to, what are your hopes for the future of healthcare and the future of your research and the overall future of osteoarthritis? Okay.
So
talk to me.
So I'll start with osteoarthritis and then I'll move on to health in general.
Yeah.
So my hopes for osteoarthritis is really that we find next time we do a really big study to see what sort of care people are receiving for osteoarthritis in Australia, that we can say, oh, look at that. Most people are getting what they actually need and deserve for their osteoarthritis, because at the moment we know that now 30 to 40% might receive what they need, and the rest, and 60% of people are just not receiving the care that they need. So that's my big hope for osteoarthritis, is that, you know, in the next 5 years we find that story's really turned around and that people are really offered that best evidence care for osteoarthritis, starting with support for self-management, exercise and weight control. Okay. Sounds really simple, but getting that working and implemented into our healthcare system, that would just be amazing. So that would be my vision for osteoarthritis. For healthcare, I think we've got a long way to go in realising that we need to be really interprofessional and interdisciplinary in the way we treat chronic diseases. So as we spoke about earlier, we know there's a lot of shared risk factors between osteoarthritis and things like heart disease and diabetes. And we're just not harnessing well enough those risk factors and also the lifestyle management that we can use to improve all of those things together in a really holistic way. So that would be my next vision for the healthcare system overall, is that as health professionals we get much better at talking to each other and working out what each other do and knowing when we can pull each other in to help our patients.
So important.
And really important, and work together.
It's an ecosystem at the end of the day.
Absolutely. Yeah. And I think that's a huge issue, and we know that is that a lot of health professions don't know what each other do. So that sounds crazy, but it's true. And then to be able to actually deliver that care in a really cost-effective and coordinated way, keeping the patient at the very centre of everything that we do, and trying to view a person as a whole person, not just trying to eke out the same treatment to everybody, but really tailor it to people's individual needs. And I think we need that as a healthcare system. I think that's really, really important.
Amazing. Thank you very much, Dr. Jillian. But just to finish off, obviously HPG Engage, the podcast, the company is called HPG Engage, or HPG. We're a healthcare professionals group, so we recruit across all aspects of healthcare. So just to finish off, do you have any tips and suggestions for anyone who may be thinking about taking a similar career path to you, and how they can actually navigate that?
Sure, absolutely. So my first tip is, although it does sound a bit of doom and gloom with the funding and research and how difficult and competitive it is still an amazing career, because you get to pursue your passions, which is incredible. So you get to do what you love every day, and that privilege is amazing. My next tip would be, if you're working full-time and trying to do a PhD and juggling a family, that's probably not a great way to do it.
We'll make things slightly
because that's
harder.
what I did. I did a part-time PhD over 6 years, and it was quite arduous and probably not something I'd recommend. And my 8-year-old, when I finished my PhD, said, "Oh, great, Mum's got a PhD and now I'm getting my mum back."
I was like,
that's not so good. Yeah, so I probably would recommend, if you can actually do it, try and do your PhD full-time, focus on it.
Yeah.
And then move on. And my other tip would be, if you're thinking about doing a PhD or a Masters of Research, make sure what you're doing in your work counts, and that it's publishable, so that you then start developing your track record.
Awesome.
And when you get your degree, you've got those publications, and you've got a head start on the start line.
Amazing. Dr. Jillian, thank you very, very much for sitting down with me today. It's been an absolute pleasure. Really enjoyed your career progression, what you've been doing, and yeah, thank you very much.
Thanks very much for having me. It was an absolute pleasure.